So we can move on now, I think, to Medhat's final case. So we've moved from fetal medicine cases to fetal cardiology to demonstrations of stick, and now we're going to move to obstetric fetal medicine cardiology cases and challenges and diagnostic concerns and all that sort of thing. So Medhat, it's your number 4 case, I think, and that'll round us off for this evening.
Hello again, everyone. I hope that you found the webinar to be informative and enjoyable so far. I will now start presenting my second case, cardiac case, which is regarding outflow tract. And as before, I will start with a quick background about the patient. This is a 32 years old patient who just moved recently into Qatar. She was in her second pregnancy. She gave a history of her previous child having had a VSD, which was diagnosed postnatally and required repair at her home country. She arrived at around 30 weeks of gestation, and she had her first ultrasound scan at that point in a private clinic. And she was referred to Sidra MFM for a second opinion. Usually we see patients within 24 to 48 hours, but because of the patient's own circumstances, she ended up being seen for the first time at around 33 weeks. So on her scan at Sidra, we performed the full anomaly scan, which did not show any extra cardiac abnormalities. On the actual cardiac scan, as usual, we started with the orientation of the fetus, because this is really critical in diagnosing any cardiac condition and many other anomalies. So this baby was cephalic, head down, and the spine of the baby was towards the maternal left, which on the axial view would show that the left side was down and the right side was up. And by looking at those two images on the left or on the right, we can see that the orientation of the heart was normal and the 4 chambers view was essentially normal. Again, which side is right and which side is left is not only the direction of the ventricle, but also morphologically, that should be double checked. And as we could see, that the right ventricle anatomically and morphologically was on the right hand side or on the right side of the baby, and the left ventricle was on the left side. So on the video clip that you can see on the left hand side on the gray scale, we can see that again the 4 chambers view appears to be normal, essentially with an intact interventricular septum. As we carry on with the scan to demonstrate the outflow tract, we can see that they exit the heart in parallel. And we can also see that what looks like a pulmonary artery at the bottom, because it shows a bifurcation, just starting to bifurcate there. And the top vessel, which appears to be the aorta, is originating from the right ventricle towards the right side, starting to form the arch, and there is an area of coarctation there. There's a little bit of stenosis as it's starting to show the aortic arch. So I'm just going to show the video again, and you can just notice this near the end of the clip. And on the right hand side, using the color Doppler, on 1 or 2 of the views we suspected a small VSD, but that was excluded in later scans and was also excluded on the echo performed by cardiology. And as we move up towards the baby's head, we could not demonstrate the outflow of the aorta and the pulmonary crossing, which is what's expected to see in normal anatomy. And in the meantime, we've seen that both arteries are exiting the heart in parallel. So that was the views that we've seen. And obviously what was suspected at that point was a transposition of the great vessels. Again, on the left-hand side and the right-hand side, you can see that the pulmonary artery is originating from the left ventricle, which is towards the left and starting to bifurcate. And the aortic artery is originating from the right ventricle and starting to form the aortic arch with an area of coarctation. So at that point, the diagnosis was a dextro-TGA or DTGA, with the coarctation of the aorta. The VSD was intact, and that diagnosis was confirmed later on the echo performed by the cardiologist. The next step was obviously to get the MDT around, which has included the MFM, obstetrics, pediatric cardiology, and cardiosurgeon. And there were multiple discussions about the outcome of the baby and the postpartum management. The patient was induced at 39 weeks and 4 days, and the diagnosis was confirmed postnatally. I will expand on the postnatal progress following the presentation, again, due to the shortage of time. So diagnostic features of DTGA. So a normal 4 chambers view, essentially, the pulmonary artery is posterior, bifurcates, arises from the left ventricle. The aortic arch gives rise to the arch, head and neck vessels, and arises from the right ventricle. There is a 50% chance of a VSD, 25% of coarctation of outflow obstruction, and coarctation of the aorta in 5%, and some cases with abnormal coronary artery. So effectively, the DTGA pathologically is a ventriculoarterial discordant lesion in which the aorta arises from the right ventricle and the pulmonary artery from the left. In the dextro type, D-loop type, the ventricles are oriented so that the right ventricle is positioned correctly towards the right of the left ventricle, and the origin of the aorta is anterior and rightward to the origin of the pulmonary artery. It is a form of a cyanotic heart disease, as there are 2 parallel circulations. The LTGA or the levo type of TGA can be discussed after the presentation, and it's very important to differentiate between both types. It is about 2 to 5% of 10,000 live births. It accounts for approximately 3% of all congenital heart diseases, and almost 20% of cyanotic heart defects. The DTGA is not usually associated with any particular genetic abnormality or familial inheritance pattern, which is good news. And the prevalence of CHD, congenital heart disease, in siblings of affected children is no higher than the background population. And it is rarely associated with non-cardiac abnormalities, as we demonstrated on our anomaly scan. Associations, as I mentioned, ventricular septal defect, left ventricular outflow obstruction. There are incidences of mitral and tricuspid valve abnormalities and coronary artery variations. So epidemiology and clinical presentation, the findings depend on the degree of the mixing between the 2 circulations or 2 circulatory systems and the presence of other cardiac anomalies. The findings are usually cyanosis and tachypnea. Murmurs may be present if there is a VSD or left ventricular outflow tract obstruction. There can be some diminished femoral pulses that might be seen in patients who also have coarctation of the aorta or interruption of the aortic arch. So the differential diagnosis would be mainly the double outlet right ventricle and the tetralogy of Fallot. And hopefully there will be some time to discuss the ultrasound differences and clinical differences in the live part of the webinar. Thank you very much.